Hi guys, so this is the E&M tutorial video that I'm putting together for you. First, let me apologize if my dogs start barking or if you can hear my one dog snoring very loudly in the background. She's kind of old, so, it happens from time to time. Okay, so we went through a lot of this stuff in the lecture, but just a recap, I tried to condense a lot of information into about 10 slides to try to make it a little bit easier for you. So if you need a little bit of clarification on what exactly an E&M service is, here's some examples for you. And what you need to primarily remember when we're talking about E&M services is that they are just that. They are services, not procedures. We assign a procedure code to a service that the physician provided to a patient. So services include examination services like evaluation, consults, treatments, conferences, counseling with patients and family, and also preventative medicine. We also bill for critical care services, services provided in the emergency room, home care, nursing homes, custodial care, hospice, or assisted living facilities. Let me fix this really quick. There we go. Make it easier for you to see. Components of an E&M code, we have the history, examination, and medical decision making. And as you can see, there are 3 keys by these first 3 bullet points, and that's because those are the 3 keys that have to be a part of every E&M code. We also have counseling, coordination of care, nature of presenting problem, and then there's a time factor that we can also bill for as a component. Okay, so code selection. This section is going to instruct you on how to select a level of each of the 3 key components, the 3 things that we have to build an E&M code. So this is going to allow you to successfully select the appropriate code for billing purposes, and the goal here is to select the appropriate code based on location of where the patient was, where they were seen, the level of the visit, and then using those key components as a guide. Okay, so location first. The first thing that we're going to figure out is location. We need to find out where the patient was being seen. Was it outpatient facility or an office? Was it hospital observation? Did we see the patient as a hospital inpatient? Were they in the emergency room, a nursing facility, or a rest home, custodial, anyplace else? The next thing we need to figure out once we figure out where the patient has been seen is whether or not the patient is new or established. So a new patient is someone that has not received any professional services from the physician or a physician in the same practice of the same specialty. To meet coding levels for new patients, 3 of the 3 key elements, history, exam, and medical decision making, must be adequately met. This is going to be the case for everything that says new or initial. An established patient, in order to meet the coding levels for established patient visits, only 2 of the 3 key components. So history, exam, and medical decision making, still the same 3 key components. We only have to meet 2 of those. So for example, you could have a history and exam and medical decision making, or a history and medical decision making, and all of those would be sufficient to count as an established patient. Okay, the history of present illness is a chronological description of the development of the patient's present illness from the first sign and or symptom or from the previous encounter to the present. It includes, these are things you need to know: location, where the problem is located, what part of the body hurts, what part is sore, where are you experiencing symptoms from. Quality, things like is it sharp, dull, stabbing, throbbing, that kind of stuff. Severity, so usually we'll ask them to rate that on a scale of 1 to 10. You probably have been asked at some point in your life, on a scale of 1 to 10, what's your pain right now, with 1 being the lowest and 10 being the worst. Duration, how long has the symptom been present? Timing, how long it lasts and when it occurs. Context, like is it improved upon walking? Does it get worse when you lie down? That sort of thing. Modifying factors, like it's, you have a sore leg, but it tends to improve if it's being iced. And then any associated signs and symptoms, so visible swelling, redness, inflammation, oozing infection, anything like that. Okay, so once we figure out the history present illness, we have two options for coding. It's either going to be brief, which will consist of 1 to 3 elements of the HPI, or it's going to be extended, which will consist of at least 4, which means, let me flip back here, we looked at 1 to 3 of these elements here for a brief, or we looked at 4 or more for an extended. Okay, so moving on, we have a review of systems. The review of systems is an inventory of body systems, which is obtained through a series of questions seeking to identify signs and or symptoms that the patient may be experienced or has experienced. This is not a list of medical problems or conditions. We are just trying to review the signs and symptoms that are associated with their chief complaint. So you have 3 types. You have the problem focused, and that inquires about the system directly related to the problems identified in the history of present illness or the chief complaint. I put a little documentation tip down here just to help you figure out where to look in case you ever want to save these PowerPoints or review these videos later on while you're working. But documentation tip, the patient's positive responses and pertinent negatives for the system which relates to the problem must be documented. For example, if they come in with a headache and you ask them if they have any pain behind the eyes and that's a negative, they say no, then you want to document that because that will help decide what level of concern and treatment that they need to address this headache with. So extended problem focus inquires about the system directly related to the problems and that are identified in the HPI, which is also the chief complaint, and a limited number of additional systems. So the patient's positive and pertinent negative responses have to be present for 2 of 4 systems, and those have to be documented in order to bill and code for an extended review of systems. So problem focused only focuses on whatever they came in for that day. Extended focuses on what they came in for that day plus 2 to 4 more systems. A complete review of systems, you guessed it, reviews all of the systems. So you can read those criteria there. Okay, past family social history. The PFSH consists of a review of 3 areas. We have the past history, which is the patient's past experience with illness, operations, injuries, and treatment. We have the family history, which is a review of the medical events in the patient's family, including diseases which may be hereditary or place the patient at risk. We want to know about those. Social history is an age-appropriate, notice age-appropriate, probably won't ask a 5-year-old if they have a history of alcohol abuse. So age appropriate is kind of a big deal there. An age appropriate review of past and current activities. So we have 3 options here. The third one is not an option that we really like to use. We only use that typically in emergency situations. So the first 2, pertinent PFSH, is a review of the history areas directly relating to the problems identified in the chief complaint or HPI. So for pertinent PFSH, at least 1 specific item from any of the 3 history areas, past history, family history, social history, must be documented. For the complete PFSH, that's a review of 2 or all 3 of the PFSH areas. Again, past history, family history, social history, depending on the category of E&M service. A review of all 3 areas is required for services that, by their nature, include a comprehensive assessment of the patient. A review of 2 of 3 areas is sufficient for all other services. Okay, and then unobtainable, like I said, we don't like to use this one, but if the patient is unable to give you any part of the history component due to their condition, you must document that condition. Examples: the patient is unable to obtain, or we're unable to obtain patient history because the patient is unconscious. Unable to obtain history, patient is a poor historian, which means they can't remember what has happened to them. Unable to obtain history, patient is on a vent and sedated. If they have a vent and they aren't conscious, probably not going to give you a history. Obtained partial history from sister, patient is confused. So if a patient is elderly or is disoriented or is mentally incapacitated in some way or shape or form, but you have to obtain partial history from somebody who may not know the patient's entire history, then you want to document that also. Okay, deciding levels of history. I put this little table in here for you with some examples. So you want to select how many components you have in each section. You must have 3 components of all the same level to get the overall level. So you can choose a lower level if the 3 components selected aren't equal. For example, here, this patient has an extended HPI. So HPI extended. Then we have a complete review of systems. So that drops down here to this level, to the extended level. Then we have a pertinent PFSH, and that goes back up here to this level. So since we only have 1 on the extended level, on the comprehensive history, and we have 2 on the detailed history, we would have to build this as a detailed history. So you would pick the code for detailed history instead of comprehensive, because we meet the criteria here with 2 of the 3. Here, down on comprehensive, we only meet the criteria, we do not meet the criteria because we only have 1 of the 3 selected here. Okay, examination levels. To qualify for a given level of examination, the following content and documentation requirements must be met. We have problem-focused exam that must include documentation of exam of 1 body area or system relevant to the affected area that they're complaining about. For expanded problem focus, it must include documentation of exam of 2 to 4 body areas or systems, including the problem area. Detailed is 5 to 7 areas or body systems, including the affected area. And then comprehensive is documentation of exam of 8 or more body areas or systems. Okay, so the last component is medical decision making, and that refers to the complexity of establishing a diagnosis and/or selecting a management option as measured by the following: number of possible diagnoses and/or the number of management options to be considered, the amount of data and/or complexity of medical records, diagnostic tests, and other information that must be reviewed or obtained, and then lastly, the risk of significant complications, morbidity and/or mortality, as well as comorbidities associated with the patient's presenting problems, the diagnostic procedures, and/or the possible management options. So what I put together is a couple of charts for you. This is the chart that you have in that golden paper packet that I gave you yesterday, and this tells you, so this gives you a little bit more of a breakdown of what would be considered minimal, low, moderate, high within each of these ranges: presenting problem, diagnostic procedures ordered, management options selected. Over here, this basically tells you how to figure it out. So you must have 2 of 3 components in the same column. Going down, you may go lower than your highest selected if you don't have 2 in the same category, just like we did for history selection. So if you have 3 points in diagnoses, so that would be a moderate in diagnoses and management options, but only low level in the level of risk, which is here, then you have to choose your low as your MDM, because they're not all the way down. And we have to have 2 of 3. And so since this one is higher, we can push that back over down a level. You can build down, but you can't build up. So we'll push that down a level so that we end up having 1 here and then 1 here. Okay, so that's the basics for E&M code selection, how to build a code. So I do want to show you really quickly. I'm going to record a second video and walk through practice questions with you step by step, because I only have 15-minute time limits on these videos. So I want to show you really quickly. I made a spreadsheet because, well, I love my spreadsheets. And this is basically a checklist. So we're going to go through this when we work through these problems, but you have location, patient type, HPI, review of systems, PFSH, exam level, and then MDM. So I will make copies of these for you guys, or actually I will post it up for you so that you can use this when we work through the problems in the next video. Okay, talk to you soon.